The next category of drugs that we have to discuss in this lecture, in this video, we are going to discuss the anti-malarials and antivirals, and antivirals including HIV. Okay, so starting with the anti-malarials first. Now, to understand anti-malarials, it is important to understand the life cycle of malarial parasite. So there is a liver, right, and then there is the blood vessels, and then in the blood vessels it circulates. So like this, let's see. Now in the liver, so the anti-malarials के लिए जो ये malarial की life cycle है, तो इसमें एक मच्छर भी है यहाँ पे, right? This is the मच्छर. Now see, when the female Anopheles mosquito bites, then it injects the sporozoites. The sporozoites are injected into the bloodstream. They travel to the liver. Liver में they undergo development in the hepatocytes. So in the hepatocytes, these sporozoites, they are called as hypnozoites, and then they develop into more hypnozoites, and they are injected then into the bloodstream again. So they now again go into the bloodstream, and then this is the stage where the fever etc. develops in the blood. Now some of them, they go into a sexual mode also. So I'll make it here. That is, they form gametes. So these are called as gametocytes. Now these gametocytes are taken up by the female Anopheles mosquito. Here in the mosquito, it sucks on the blood goes into the intestine where this zygote develops. These gametocytes fuse, form zygote, oocyst forms, then sporozoites are released, they again go to the salivary gland, and from there then they are again injected into the bloodstream of the human beings. So this is how this cycle goes on. Okay, hypnozoites इधर. So अब इसमें जो stages हमने develop study किए, तो इसमें the first stage, that is infection by the female mosquito, and then sporozoites are entered into the blood. Then there is a pre-erythrocytic stage. Pre-erythrocytic stage where now they're developing into the cytons are developing into the liver, and they are multiplying asexually to form hypnozoites, right? And then they in the liver में ही एक होती है pre-erythrocytic stage and एक होती है, one is exoerythrocytic stage. Okay, now what is exo? Because these hypnozoites then from the pre-erythrocytic cytons, they invade the new liver cells and develop into merozoites. That is it is like a carrier state. So they remain there for a longer time and they are responsible for the relapses, right? Then in the RBCs, now these hypnozoites, they're released, merozoites are released into the red blood cells. There in the RBCs, they develop into trophozoites, and trophozoites, say, they mature into cytont and they rupture, creating more merozoites or sporozoites, and they infect newer cells, right? So this is what happens in the red blood cell, and this is called as erythrocytic cell. And symptoms of malaria, they depend on this erythrocytic stage, okay, like fever, chills, and rigors. Now there's one more thing. In the blood, as I told you, gametes are formed. These gametocytes, they're ingested back, and then these gametocytes, they can result in a cycle which is going on and on and on if the gametocytes are there in the body. Now I have told you about pre-erythrocytic stage, exoerythrocytic stage, and erythrocytic stage. Now according to them, so pre-erythrocytic stage, what are the drugs and what is the prophylaxis called as? So when we are targeting the pre-erythrocytic stage, then the treatment is called as causal prophylaxis, because we are trying to kill the cause here. So this causal prophylaxis is when you are targeting the pre-erythrocytic stage. And what are the drugs which are used here? That is proguanil, primaquine, and pyrimethamine. These are the drugs which are found to be active in the causal prophylaxis. Then the second is erythrocytic. Now erythrocytic means in the RBCs. So the treatment which is done in the erythrocytic phase is called as clinical care, right? Or you can also call it as suppressive prophylaxis. So they kill the cytons in the blood, and they are used in acute attack and in the suppression of the disease also, right? So these drugs are used for the treatment and not for the prophylaxis. Now here we have a lot of drugs. Here we have chloroquine, mepacrin, quinine, mefloquine, halofentrin. Then we have atovaquone and even artemisinin derivatives. Then other drugs are also used: proguanil, pyrimethamine, sulfonamides, and tetracyclines. So these are the drugs which are used, which are effective in the erythrocytic phase. Then the next is exoerythrocytic. Now what are the drugs effective in exoerythrocytic? What is the treatment here called as? It is called as a radical cure. So basically you are killing the latent or the carrier stage also. So you are actually curing the whole thing. Now in radical cure, the drug which is found to be very good effective is primaquine, and this is the drug which is gameticidal also, right? And the last is gametocyte पर अगर हम killing कर रहे हैं, so what is this? We are actually doing prevention of recurrence. So it will not happen again and again. And what are the drugs which are used here? Here we have the drugs which are effective are proguanil, pyrimethamine, primaquine, and artemisinin. Okay, so these are the drugs which basically help in the killing of gametes of vivax and falciparum. Okay, now coming to the individual drugs, let us see the individual drugs of malaria. The first drug that we have to see is chloroquine. Chloroquine is the main drug which was developed for the treatment of malaria. Now this is the drug having the largest volume of distribution. How much? 1300 liters. It basically accumulates in the food vacuoles of the plasmodium. Now it is, what is the mechanism of action? This drug gets concentrated in the parasitized erythrocyte. Okay, and in the parasitized erythrocyte, it prevents the polymerization of heme to hemazoin. Okay, this results in accumulation of heme, which is toxic to the parasite. So this is the mechanism of action, and this is how it kills the parasite. Now this is the drug of choice in treatment and prophylaxis of non-falciparum malaria, and also chloroquine sensitive plasmodium falciparum malaria. Okay, this drug basically it's an erythrocytic syngentocyte. Okay, so it is applicable only on erythrocytic phase and not effective in exoerythrocytic phase. Then other indications. Sometimes you can ask, be asked a question also that what are the following are the uses of chloroquine except. So uses of chloroquine में सबसे पहले मलेरिया है, then rheumatoid arthritis, then extra intestinal amoebiasis, okay, discoid lupus erythematosus, lepra reaction, infectious mononucleosis, photogenic reactions, then also giardiasis. So these are the various uses of chloroquine. Now, what are the adverse effects? Adverse effects of chloroquine. It can result in skin rash, that is lichenoid reactions, peripheral neuropathy, hypotension, and myocardial depression, then auditory impairment, and also toxic psychosis. Right? Prolonged use can result in retinal toxicity. So prolonged use, usually it is done in rheumatoid arthritis. So what it causes is, it causes bull's eye maculopathy. Okay, then it can also precipitate porphyria, and it can also cause discoloration of nails and mucous membrane. Right? Lastly, this is also the drug of choice in pregnancy. So chloroquine is safe to be used in pregnancy. So this is the detail about the chloroquine. Now the next drug that we have is quinine. Now quinine mechanism of action is maybe similar to chloroquine also. The major use is treatment of Plasmodium falciparum resistant to chloroquine. Okay. This is usually combined with doxycycline or clindamycin, right? It is not used for prophylaxis. So quinine is not a drug for use in prophylaxis. There's another isomer, quinidine. Quinidine can be used IV for severe Plasmodium falciparum infections, right? Now, what are the side effects of quinidine? So quinidine causes hypoglycemia, palpitations, tachycardia, right? So it should always give IV quinine in 5% dextrose solution. So remember this, that quinine should always be given in 5% dextrose instead of normal saline. Then in toxic doses, toxicity होने पर it usually causes GI distress, blurred vision, vertigo, right? Tinnitus. So these are the symptoms usually seen with the quinidine toxicity. Now quinidine is also found to be safe in pregnancy and can be used in the chloroquine resistant malaria. The next drug that we study is mefloquine. Now mefloquine is basically used for, again, chloroquine resistant Plasmodium falciparum infections. It can be used for treatment as well as prophylaxis. Okay. Then adverse effects में mefloquine also causes psychosis and cardiac conduction defects and seizures, right? It is contraindicated with the halofentrin or quinine because it causes prolongation of QT interval. Mefloquine is usually given as a single dose treatment of malaria. Then the next drug is the very important primaquine. Primaquine is basically a drug. It basically it forms redox compounds that act as cellular antioxidants, right? Now this is pre-erythrocytic, erythrocytic and exoerythrocytic. So all phases, and also gametocytes. So it acts on all phases, and so it is effective in any which way, and it also kills gametes of all species. Unlike chloroquine, which is effective only on Plasmodium vivax gametes, right? Now this drug, primaquine, always used with erythrocytic cytotoxide for a radical cure. ऐसा नहीं कि अकेले दे दिया, it is not given alone, it is given along with erythrocytic cytotoxide for radical cure. It can result, there is a side effect, it can result in methemoglobinemia and also hemolysis in G6PD deficient patients. It is contraindicated in pregnancy, and it has no role in radical cure of falciparum, because this falciparum has got no exoerythrocytic cycle. Okay, so because this falciparum does not have any exoerythrocytic cycle, so it is not effective in that. Otherwise, it's used in all the infections. Then there's a drug, efenoquine. It is basically a new oral drug similar to primaquine, and this is approved as a single dose for radical cure of Plasmodium vivax malaria. Okay, so this is about the new drug. Now the next drug that we have in this category are basically antifolate agents. So in antifolate agents we have the pyrimethamine, then we have the sulfadoxine, and we also have proguanil. Now proguanil is a prodrug, and it is activated to cycloguanil, right? Pyrimethamine, we know it inhibits the dihydrofolate reductase. This proguanil also acts on dihydrofolate reductase, and sulfadoxine acts on thymidylate synthase. So together they cause a sequential block. This we have studied in the other drug, that is cotrimoxazole also. Cotrimoxazole also, that is trimethoprim plus sulfamethoxazole. Now these drugs are slow agents, and they are very good if there is chloroquine resistant falciparum malaria. And there's a combination, proguanil plus atovaquone. It is used in the treatment and chemoprophylaxis of chloroquine resistant malaria also, right? So this is one combination which is used in treatment as well as prophylaxis. You can see that mefloquine is the drug which is used in treatment as well as prophylaxis of chloroquine resistant, and this is one combination which can also be used. Then we have the drug which is atovaquone. Now atovaquone is basically a rapidly acting blood cytotoxide, and it paralyzes the parasite membrane, so it basically makes it inable. Then it proguanil के combination के साथ it is used in, as I've told you. Then atovaquone is also used in pneumocystis xerovecii infection, and also used in Toxoplasma gondii infections. Okay. Next drug that we discuss is artemisinin derivatives. Now artemisinin basically are the drugs which artemisinin के अंदर आते हैं artesunate, arteether, and artemether. So all these drugs are obtained from a Chinese herb that is called as Artemisia annua. Then this artemisinin is a prodrug, and it is activated to form dihydroartemisinin. Okay, then they generate free radicals, and these free radicals, they damage the parasitic membrane. These are the latest drugs in the treatment of malaria, and they have revolutionized the malarial treatment. Then artesunate is basically has a very short half-life, and it is given IV. These drugs can be used in multi-drug resistant malaria, right? They can also be used in cerebral malaria. They are contraindicated in chemoprophylaxis of malaria, okay? And they rarely cause any QT prolongation. Now what are the combinations of artemisinin? Usually it is called as, the artemisinin therapy is called as ACT. Now what is ACT? ACT का मतलब होता है artemisinin based combination therapy, right? Now artemisinin based combination therapy में the drug that we have is artemether plus lumefantrine. Okay, the other drug is artesunate plus sulfadoxine, pyrimethamine. Now this combination is said to be used in northeastern states, and this combination is used in rest of India. ठीक है? Then another और दूसरे जो combinations है वो है artemether plus lumefantrine, then artesunate plus mefloquine, okay, artesunate plus amodiaquine. So these are the various combinations which are used in of artemisinin. Majorly uses क्या है artemisinin based therapy के? They are used in severe complicated Plasmodium falciparum infections. Okay, so they are mainly used in a severe complicated Plasmodium falciparum malaria. The next very important another new drug that has come up for the treatment of malaria is halofentrin and lumifentrin. So they are halofentrin and lumifentrin. Okay, these are the drugs. Halofentrin and lumifentrin, these are new drugs. Now they are basically, halofentrin is known to cause severe cardiotoxicity. So it is, due to these reasons, it is not recommended, okay, for the chemoprophylaxis of malaria. And use of this drug is usually not recommended in the chemoprophylaxis. And usually the use is restricted to multi-drug resistant malaria. Okay. Now lumifentrin is a new drug which is similar and is used always with artemether. So this is lumifentrin used always with artemether. This is also important. Now let us see the treatment plans or the treatment regime. So when we talk about chemoprophylaxis, what are the drug of choice? For less than 6 weeks, we use doxycycline. For more than 6 weeks, we use mefloquine. Okay. Treatment of malaria, what is the normal regimen? If it is Plasmodium vivax, okay, then we usually use chloroquine plus primaquine. If you want to remove the this thing, dermatocytes also, radical cure and complete cure के लिए, we can add primaquine also. Pregnancy है, pregnancy you can give chloroquine, right? Then if it is Plasmodium falciparum infection, then in Plasmodium falciparum you give artemisinin combination therapy plus primaquine. If the patient is pregnant में in the first trimester you can give quinine. In the second and third trimester you can give artemisinin based therapy, right? So this is the combination therapy which is approved nowadays, and so that is basically the drug therapy of malaria. Now next we come to the drug therapy of viral diseases, various viral diseases, and in that we will complete the HIV also. So coming to the antivirals. Now before we go on to all the antivirals, it is necessary to understand the life cycle of a virus. So what is the life cycle of a virus? सबसे पहले the virus, there is a fusion of virus with the host cell. Fusion के बाद there is penetration, right? After that there is uncoating. So there is uncoating of the virus and the viral DNA or RNA is released. Then there is synthesis of early proteins, okay. Then there is, it goes into the nucleus and there is synthesis of nucleic acid, okay. Now after nucleic acid synthesis, then there is, it comes out into the cytoplasm and synthesis of late proteins, right? So late proteins are synthesized. Then after that there is packaging and assembly, right, and followed by release. So they go to the cell membrane and then they are released. Now what are the various steps? These are the steps, and so what are the various drugs which are acting at these steps? So here fusion of virus पे we have fusion inhibitors, right, which are used in HIV, that is enfuviritide, right, then maraviroc, then we have ebalizumab, and we have palivizumab. So these are the drugs which inhibit the infusion of the virus with the cell. Then the drugs which affect the uncoating. Uncoating is affected by amantadine and rimantadine. So uncoating of the virus is affected by amantadine, rimantadine. Then synthesis of early proteins is affected by fomivirsin, which is a antisense oligonucleotide. Okay, this is an antisense oligonucleotide. Then in the nucleus, when there is nucleic acid synthesis, so here we have anti-metabolites, right, in which we have drugs like acyclovir, which basically inhibit the viral DNA polymerase after bioactivation. Then reverse transcriptase inhibitors in HIV. These are the drugs that inhibit the nucleic acid synthesis. After that, formation of synthesis of late proteins. This is inhibited by protease inhibitors, again in HIV, right? Protease inhibitors, they inhibit this packaging, assembling and synthesis of proteins. Release is inhibited by, again, neuraminidase inhibitors, and their names are oseltamivir, zanamivir, and perimivir. So these are the various targets and the various drugs which are acting through these targets, right? So let's see all these drugs one by one. We'll see them as per the disease. So the drugs which are acting in herpes simplex. Now in herpes simplex, the drugs which we are using are acyclovir. Now acyclovir is a guanosine analog, and it is active against herpes simplex virus 1, herpes simplex virus 2, also active against varicella zoster virus, right? It is not active against cytomegalovirus. Now, how does it act? How does acyclovir act? So acyclovir basically gets it gets activated by thymidine kinase, and what does it form? It forms acyclovir monophosphate. Okay? Then it forms, from this it forms acyclovir triphosphate. This product competitively inhibits the viral DNA polymerase. Okay? It gets incorporated into the DNA and causes chain termination. Okay, so this is the action of acyclovir. Now acyclovir is used, it can be used by oral route, IV route, and by topical route. It has got a very short half-life, so multiple daily dosing, excreted mainly by the kidneys. Okay, then this drug is used in the treatment of mucocutaneous and genital herpes, also used in the prophylaxis of herpes infection in AIDS and immunocompromised patients. Then if you give IV administration, then it can result in nephrotoxicity and also neurotoxicity, but it does not cause bone marrow suppression. Then there is another drug, that is mycophenolate. Now this mycophenolate is an immunosuppressant, and it potentiates the anti-herpes activity, right? When the patient is on acyclovir, then maintain hydration, otherwise there is an increased nephrotoxicity, or the chances of nephrotoxicity are more. Then valcyclovir has got a long half-life, and famciclovir is a prodrug, right? So these are the various drugs. Then we have another drug, which is ganciclovir. Now ganciclovir is active against cytomegalovirus and herpes simplex virus. The mechanism of action is same. Then ganciclovir used only IV, and there is a isomer valganciclovir is used orally also. Then ganciclovir is the drug of choice for CMV, retinitis. Side effect is myelosuppression. Okay. The next drug that we have is cidofovir. Now cidofovir is basically activated by host cell kinases. It is active against HSV, then it is active against CMV, adenovirus, and it is also active against papillomavirus, right? The toxicity that cidofovir has is basically nephrotoxicity, right? Then it also causes, another is uveitis and iritis. It is also a very potential human carcinogen. Another drug, very interesting drug that we have is foscarnet. Foscarnet, basically, it is not an antimetabolite, does not require any activation. It is used in CMV infections. Then side effects may, it causes nephrotoxicity, then hypomagnesemia and hypocalcemia. These are the various side effects. Coming to other drugs that we have in herpes infection, the other drugs that can be used are vidarabine, idoxuridine, trifluridine, then fomiviricin, and docasenol. Now fomiviricin is a very interesting drug. It is an antisense oligonucleotide. So fomiviricin is the first antisense oligonucleotide, and it is also active against, it is used in CMV retinitis. Okay, so this is the a very different kind of drug, and it is given by the intravitreal route, right? Then idoxuridine is basically used topically for keratoconjunctivitis by HSV, right? Then there's a drug docasenol. Docasenol is a long chain, it is actually a long chain saturated alcohol. It is used topically as a cream for herpes labialis. Okay, it prevents the entry of the virus in the cell. Then there is a new drug, letermovir. This is a cytomegalovirus DNA terminase complex inhibitor, right? And it interferes with virion maturation and is used for prophylaxis of CMV infection, right? Then after this herpes simplex के बाद आता है smallpox. Now smallpox, as we all know, that it is almost eradicated, but there is always a risk of bioterror attack. So इसके लिए एक new drug है, that is ticovirimat. It is a new drug that has activity against orthopox and smallpox and monkeypox viruses. Okay, so this is the drug. Then doses, many doses are basically, they are stockpiled in USA to counteract any bioterror attack in smallpox. Then there is Ebola virus. Now the first treatment for Ebola virus is hydration by fluids and electrolytes. Then second is monoclonal antibodies. They have been developed that target viral surface glycoprotein and prevent the entry in the cell. Then all these drugs are approved for the Ebola virus, Zaire Ebola virus. The drugs that are given are atoltivimab plus mavtivimab plus odesivimab. So these are the drugs which are approved. A new drug is there, that is ancivimab. This is also approved for this particular indication. Okay, next we have anti-influenza. So the drugs which are active against influenza, H influenzae. Isme the drugs that we have are amantadine and rimantadine. Now, as we have seen earlier, they basically inhibit or prevent the uncoating, right? So now rimantadine here is longer acting than amantadine, and इसके जो इनके adverse effects होते हैं usually GI upset and minor CNS effect. Amantadine is also used in Parkinsonism. Okay. The other drug that is used in influenza is oseltamivir and zanamivir. Now these drugs, they are basically neuraminidase inhibitors, right? They are what? Neuraminidase inhibitors, right? They prevent the release of the virion. They are active against both influenza A and influenza B. Oseltamivir. Now, let's take another page. Oseltamivir is a prodrug, right? And this is mainly given by the oral route, and zanamivir is given by inhalation, and a major side effect it causes is bronchospasm. Then there are neuropsychiatric disturbances like suicidal tendency also. They can be used prophylactically. They're used in epidemic. Then oseltamivir is the drug of choice for bird flu, that the current one is H5N1, and also for swine flu, that is H1N1, right? Then we have peramavir. It's a new drug which is administered intravenously. And then we have laninamivir, which is a long-acting inhaled neuraminidase inhibitor, right? Then there is, sorry, I can't see it. A new drug is also there, which is baloxavir. This is single dose oral treatment of acute uncomplicated influenza, right? It interferes basically with the endonuclease activity, and so it inhibits the viral replication, right? So these are the drugs which are used in influenza. Now let's come to the hepatitis. Hepatitis, we know, are of hepatitis A, B, C, D, and E. So what are the drugs which are used in hepatitis? The drugs which are used in hepatitis are interferon alpha, then lamivudine, ribavirin, and entecavir, adifovir, and telbivudin, right? Now the goal of HBV therapy is to suppress, and goal of HCV therapy is to eradicate. Okay. Now what are interferons? Interferon, they basically act by the JAK-STAT pathway, and to basically increase the antiviral proteins, right? They also increase the NK cells, that is the natural killer cells. Now they are used in chronic HBV infections. Then along with ribavirin plus interferons, they are also used in HCV infections, right? Then there is another category of these drugs that is called as pegylated interferon alpha 2A and 2B. They are superior to conventional interferons. Okay. Now pegylated ones are more superior. Another thing that we have intralesional interferons are also used in verruca vulgaris and condyloma acuminata. There's another drug which is called as imiquimod. This is an immunomodulator and this drug is also found to be effective in HBV infections. Then other drugs that are used in HBV and HBC, one is lamivudine. Now lamivudine is basically a nucleoside reverse transcriptase inhibitor. This is mainly used in the treatment of HIV, and it can be used alone or in combination with interferon alpha for chronic HBV infection also, right? Then another drug that we have to see is ribavirin. Ribavirin has got a very wide antiviral spectrum. It can be given orally also. Then it is used with interferon alpha in chronic HCV infection. Then although it does not have any effect in respiratory syncytial virus, still it is recommended. Then it also causes dose dependent hemolytic anemia. It is a known teratogen. It is the drug of choice for chronic HBV. The drug of choice chronic HBV is entecavir, and for HCV, both acute and chronic, the drug of choice is pegylated interferon alpha 2A plus ribavirin. This we have seen earlier also. Another drug is entecavir. Entecavir is a new HBV viral DNA polymerase inhibitor. It is effective against HBV resistant to lamivudine, and it has become the first line drug for chronic HBV infection. Then next drug is adifovir. Okay, adifovir is an anti-metabolite for HBV. The only adverse effect that it has is nephrotoxicity. Then it causes lactic acidosis with hepatomegaly and steatosis, right? Then there are some new drug for hepatitis C virus. Now these drugs are effective orally also. They can be taken orally. They have HCV protease inhibitors, which are called as NS3A/4 inhibitors. Then we have NS5A inhibitors. Then we have RNA polymerase NS5B inhibitors. They are used as first line drugs for hepatitis C in different combinations. Okay, so these are the drugs which are used in HCV. Now we come to just an overview of drugs which were used in COVID-19. So here the targets, various targets of drug therapy are first is virus entry inhibitor, then second is RD/RP inhibitor, third is importin inhibitor, and fourth is immunomodulators. So these are the targets for COVID-19. So in virus entry inhibitors, we have chloroquine, which is effective. Then a new drug was there, omifenovir. Along with chloroquine, even hydroxychloroquine is found to be effective. And then we have chemostat and nefamostat, and then we have monoclonal antibodies, right? So these are the drugs which they will inhibit the entry of the virus into the cells. The second, that is RNA dependent RNA polymerase inhibitors. So इसमें जो drugs हैं वो है remdesivir and favipiravir. Okay, so remdesivir is basically an adenosine analog. It is administered IV, and it is FDA approved for the treatment of COVID-19, not WHO approved, right? So this remdesivir was indicated in moderate to severe COVID-19 hospitalized patients, then patients on oxygen therapy, and within less than 10 days of disease onset. So this was about remdesivir. Then the third category, importin inhibitors, right? So importin inhibitors, what are the drugs which come in that? In this we have ivermectin. Ivermectin is supposed to inhibit the importin protein, and by this mechanism it prevents the hijacking of the cell by the virus. Then it was discontinued due to lack of efficacy. And the fourth category is immunomodulators. Now in immunomodulators, several drugs are used to inhibit the overactive immune system in the patients. Then steroids were there. Steroids were used to decrease the mortality. It was seen that they are the only drugs which decrease the mortality, right? And adverse effects, like in what were the adverse effects of steroids? It was mucormycosis. Then another very important drug was used, tocilizumab. And what is tocilizumab? Tocilizumab is basically interleukin-6 monoclonal antibody. So it is used intravenously, and it was seen in patients with cytokine storm, especially to prevent the cytokine storm. and also tocilizumab to be avoided in immunocompromised patients, and a lot of other common other indications are also there. So overall, agar in mild COVID, basically the drug that is given in is inhalational budesonide that can be given antidepressives. These, if it is moderate, that is SpO2 is less, then you give steroids, you give anticoagulants, okay, and other therapies. Then if it is severe, so respiratory rate is high, SpO2 is less than 19, then oxygen to dena hi hai, steroids have to be given, anticoagulants to be given, and other drugs also, and other drugs, right? So this is the basic treatment for COVID-19. Now let's go to the main viral infection, that is HIV. So what are the drugs which are used in the treatment of HIV, and what therapies to be given? So now talking about HIV drugs. HIV drugs are very interesting, and I really love this topic. So let's discuss first to see the life cycle of HIV virus. So if I say this is the cell, right? Now the HIV virus is coming from here. So this is the entry. Entry mein yahan pe there are they usually affect the CD4 plus helper T cells. Now CD4 molecule is one major important thing. So there is this receptor, say CD4, and then there are co-receptors CCR5 and CXCR4. These are the receptors through which the HIV virus it attaches. Okay, so this is the HIV virus, right? Now this is attaching here. So now this entry point or fusion inhibitors. एक यहाँ पर target आएगा fusion inhibitors, right? Now fusion inhibitors में the drugs that we have are enfuviritide, okay. Then we have CXCR4 antagonist, that is maraviroc, and also ibalizumab. So these are the drugs which are in entry or fusion inhibitors. Next, after that, this virus comes inside. Now this virus comes, I'll make it with blue, and there is viral RNA is released, that is uncoating of the virus. After this, viral RNA is then converted to DNA, right? So this RNA to DNA conversion takes place by reverse transcriptase enzyme, right? So we have this reverse transcriptase inhibitors here. And what are these reverse transcriptase inhibitors? Now there's a full classification of reverse transcriptase inhibitors. We'll see that in detail. In this we have nucleoside reverse transcriptase inhibitors. Then we that is nucleoside reverse transcriptase. Then we have non-nucleoside reverse transcriptase inhibitors, and we also have a nucleotide reverse transcriptase inhibitor. Okay. After that, so here we are inhibiting the conversion of viral mRNA to DNA. Now this viral mRNA DNA is now going to integrate in the nuclear genome. The nucleus of the cell is here, and in this the host genome is there. So this goes and it undergoes integration, that is integrase enzyme, which carries out the integration into the host genome. And this integrase enzyme is inhibited by drugs which are raltegravir, elvitegravir, cabotegravir. Sorry. So these are the integrase inhibitors. Now suppose the virus has got integrated and then it undergoes DNA बनता है. यहाँ पे सब कुछ हो गया. DNA से फिर बनेगा RNA. So this produces viral RNA, which is integrated with the host, and then after replication it comes out. Then it forms proteins by translation, and these are inactive or immature proteins, and then they get converted into active viral proteins. And just like I told earlier also, that there is packaging and assembling will happen, and then finally a virus will be formed, and this will be released, which is called as budding, right? So here this proteins packaging and assembling, so this is inhibited by protease. So sorry, this is done by protease. So we have protease inhibitors. So in protease inhibitors we have drugs like ritonavir, saquinavir, then nelfinavir, then we have amplinavir, fosemplinavir, then lopinavir, darunavir, and tipranavir. Okay, so these are the drugs which are protease inhibitors. And so here then there is a budding, and then a mature HIV virion is released for infection of the remaining cells. So just to summarize this whole process, so the drugs, anti-HIV drugs, are divided into reverse transcriptase inhibitors. They are further divided into NRTIs and NNRTIs. Then we have protease inhibitors. Then we have entry or fusion inhibitors. And we have integrase inhibitors. In nucleoside reverse transcriptase inhibitors, we have nucleoside drugs, and we have nucleotide reverse transcriptase inhibitor, and these are non-nucleoside. So let us see the names of nucleoside reverse transcriptase inhibitors. In this we have zidovudine, which is the first prototype drug, then stavudine, lamivudine, zalcitabine, diadenosine, then abacavir, and M3-citabine. So nucleoside in reverse transcriptase inhibitors में आते हैं zidovudine, stavudine, lamivudine, zalcitabine, diadenosine, abacavir, M3-citabine. And in nucleotide reverse transcriptase inhibitor we have tenofovir. And in NNRTIs we have efavirenz, nevirapine, Itravirin, Delavirin, Rilpivirine. Okay. Then protease inhibitors I've named there, fusion inhibitors I've named there, and integrase inhibitors also I've named there. So these are the major drugs that are used in the treatment of HIV. Now let's see them one by one. Let us see all the anti-HIV drugs one by one. They are very important, and it is very important that you remember all of them and complete them. So coming to the nucleoside reverse transcriptase inhibitors. Now these drugs, as we all know, that there is this enzyme that is RNA dependent DNA polymerase, which is also called as reverse transcriptase. So this enzyme is inhibited competitively or non-competitively. Now this non-competitively is done by non-nucleoside reverse transcriptase inhibitors, and competitively is done by nucleoside reverse transcriptase inhibitors, right? Now the first drug in this category is zidovudine. So zidovudine is frequently used. It is used for the prophylaxis, also used for prophylaxis of needle stick injury patients, then used for prevention of vertical transmission from mother to fetus, right? Adverse effect of zidovudine is bone marrow suppression, then myelodysplastic anemia and neutropenia and thrombocytopenia. Do not combine ganciclovir. Okay. Also, it is contraindicated if hemoglobin is less than 8 gram %. It can also show myopathy. Okay. If you give rifampicin, then rifampicin has an interaction and it increases the clearance of zidovudine. Okay, so with rifampicin you have to be very cautious. The other side effects are nail hyperpigmentation, lipoatrophy, that is also caused. The next drug that we have is diadenosine. Now diadenosine is another NRTI. This basically adverse effect is somewhat specific, that is it causes pancreatitis, optic neuritis, hyperuricemia, and it can also cause peripheral neuropathy. Next is stavudine. Stavudine causes main toxicity is peripheral neuropathy, right? It also causes lactic acidosis, can also cause pancreatitis, right? The next drug we have is lamivudine and emtricitabine. So lamivudine and emtricitabine, they are very good NRTIs. They are not associated with pancreatitis or peripheral neuropathy. So they are, and they are also effective in hepatitis B infection. Emtricitabine is an alternative to lamivudine. So once a day is OD lamivudine. Instead of lamivudine, we can also give emtricitabine. Now here a very important thing, that drugs effective in hepatitis B, anti-HIV drugs. So that means they are effective in HIV and HPV both. Here we have lamivudine, emtricitabine, and tenofovir. So these are the three antiviral drugs, anti-HIV drugs, which can be effective in hepatitis B also. Okay. Then आगे बढ़ते हैं. So we have zalcitabine. Now zalcitabine has unique toxicity. It causes oral ulceration and stomatitis. It is least effective NRTI, right? The next is abacavir. It increases the risk of myocardial infarction. Then all NRTIs are excreted by kidney except abacavir, which is metabolized by the enzyme alcohol dehydrogenase. So it has got a major side effect of hypersensitivity. Okay. Then toxicities, I've already told you that all NRTIs, they cause lactic acidosis, hepatomegaly, and steatosis also. Maximum risk of pancreatitis is by diadenosine. Then peripheral neuropathy is by stavudine, and lipodystrophy is by again stavudine. Then we have a nucleotide reverse transcriptase inhibitor, that is tenofovir. So this is a nucleotide and it does not require any bioactivation by any kinase. It is excreted by kidney. So in renal impairment can result in Fanconi-like syndrome. Oral bioavailability increases with meals, causes flatulence. This is the only significant side effect, and it is also used in hepatitis B viral infections. Okay. Then we have NNRTI. So in these drugs, they basically inhibit the reverse transcriptase by acting at allosteric site. They are selective for HIV-1 and no action on HIV-2. Resistance develops rapidly. So the drugs in this group are efavirenz, nevirapine, etravirine and delavirdine. Okay. Now individually अगर देखें, so nevirapine is used in pregnancy to prevent vertical transmission. So single oral dose is given to the mother and to the neonate within 3 hours of birth is found to be effective. Then it also decreases transmission to 13%. However, it causes hepatotoxicity, so it is not really preferred. Then efavirenz. Efavirenz is basically neurotoxic and it also results in hallucinations and vivid dreams. So this is one problem with the efavirenz. Etravirine is a recently new approved drug hai. It's a second generation. This is active against HIV, which is resistant. HIV बोल सकते हैं, resistant to the first generation drugs. And another new drug that has come is rilpivirine. Okay, and there's another drug that is doravirine. So these are recently approved NNRTIs, right? Now delavirdine is again a first generation drug. उसमें भी ज़्यादा इनके use नहीं होते. Secondly, these drugs can also cause skin rash. Rash is one major problem. Stevens-Johnson syndrome and toxic epidermal necrolysis. These are the side effects of NNRTIs. Okay. Now coming to the protease inhibitors. So in protease inhibitors, they help in the basically this enzyme protease. What it does, it basically helps in the maturation. Proteins तो बन गए, अब उन proteins gag pole and उन proteins का जो packaging होता है, उन virions का पूरा making होता है, maturation होता है. So that is done by this protease. So when we inhibit this protease, then the virions are not matured and as a result the HIV infection does not spread. So the drugs, important drugs we had written earlier also. Let us see them one by one. So indinavir, oral bioavailability is decreased with food. Then it can cause crystalluria and kidney stones, right? So good hydration is required. So when you are giving indinavir to a patient, give good hydration. It can also cause asymptomatic hyperbilirubinemia. Okay. Then next, basically these protease inhibitors, they inhibit the cytochrome P3A4 enzyme, and so they inhibit the metabolism of many drugs. So a lot of drug interactions are seen. Now ritonavir in low doses is used with the protease inhibitor to increase their plasma concentration. Now currently the guidelines say that add ritonavir to all protease inhibitors, right? Only 2 drugs, nalfinavir and atazanavir, are used safely without ritonavir boosting. Then concentration of, there is a drug amprenavir and iska congener hai fos-amprenavir. So concentration decreases with ethinyl estradiol if they are taken together. Then tipranavir is the only non-peptide protease inhibitor, right? It is effective against HIV, which is resistant to other protease inhibitor. But tipranavir can cause hepatotoxicity and it also causes intracranial hemorrhage, right? Then we have atazanavir. Then atazanavir causes asymptomatic unconjugated hyperbilirubinemia, and it also increases the PR interval in ECG, right? Next, amprenavir can also cause Stevens-Johnson syndrome. That is also there. Then they also can cause metabolic abnormalities like hypercholesterol, diabetes mellitus, hyperlipidemia, etc. Atazanavir does not cause these side effects. Then there is a drug tisamorelin, which is basically synthetic. This we had studied in the endocrine. Synthetic analog of growth hormone, releasing hormone, which is indicated to reduce excess abdominal fat in HIV patients with lipoatrophy. Okay, this has been asked as a question also. So tisamorelin is the drug which is used in this purpose, right? Then next we have drugs which are entry inhibitors. So in entry inhibitors, अब entry जो है basically when the HIV enters, there is an interaction between the viral glycoproteins and the proteins which are present on the CD4 cells, right? So now the two glycoproteins are GP41 and GP120, which are present on the viral proteins, and they bind to CD4 receptors, right? Now there are co-receptors also, CCR5 and CXCR4. So the drugs, they bind to these proteins also and inhibit the entry of the virus. So GP41 को जो bind करने में inhibit करता है, that is enfuviritide, right? Then GP120 is inhibited by fostemsavir. Then CD4 is inhibited by ibalizumab, and CCR5 is inhibited by maraviroc. Okay, so these are the important entry fusion inhibitors. Now ibalizumab is a monoclonal antibody against CD4 receptors. Enfuviritide, it binds to the GP41 subunit of HIV and inhibits the fusion. It can be used subcutaneously, but it causes site reactions also, hypersensitivity and pneumonia. Then it is active only against HIV-1 virus. Then fostemsavir, this one. This is not fostem, this is fostemsavir. This is an oral prodrug, okay, of temsavir. Then it inhibits the entry by binding to GP120, and it also causes QT prolongation. Then increase in hepatic transaminase and immune reconstitution syndrome. Then maraviroc is the first CCR5 co-receptor antagonist, and it is active only against CCR5 tropic virus, right? And it can be given orally also. So these are the fusion or entry inhibitors. Now the next category of drugs that we have to discuss is the integrase inhibitors, right? Now what are integrase inhibitors? The drugs that are there are raltegravir, elvitegravir, and bictegravir. Now these are basically these are oral drugs. They are approved by FDA for the use in HIV, and there is a drug which is called as CoB-C-Stat. It is used to boost the effect of elvitegravir, right? So CoB-C-Stat also increases the effect of other darunavir, and also atazanavir. Okay. Then we have another combination, that is rilpivirine plus cabotegravir. This is used in once monthly IM injections for HIV. Okay. This is also one new drug. Then there is another compound that is called as ilapegadimase. Now this is a recombinant adenosine deaminase ADA enzyme, right? It is indicated for intramuscular injection in severe combined immunodeficiency syndrome due to ADA deficiency. Okay. Now let us see what is the therapy. The therapy for HIV is called as HAART, heart. That is highly active antiretroviral therapy. It is also called as combination ART. It is recommended. The primary goal is to reduce the viral load to less than 50 copies per ml. Okay. Now what is the latest regulation regarding HIV? Let's see that. So the first thing is when to start ART. Now when to start ART? ART to be started in all HIV positive patients regardless of the stage and CD4 cell count, right? This is the first thing that has changed now. Earlier they used to start it late. Then if patient is having TB plus HIV, then start treatment of TB first, followed by ART as soon as possible in 8 weeks of treatment, right? So this is very important, and a lot of questions have been asked on this also. Then next होता है what to start, मतलब क्या शुरू करना है, what is the first line therapy and what is the second line therapy. So in adults, now please listen to this carefully. Adults में the preferred first line ART, we have to start 2 NRTI plus 1 NNRTI. Okay, so this is the treatment plan. Now in this, usually the combination that is given is tenofovir plus lamivudine or emtricitabine plus efavirenz. So this is the treatment plan, the first treatment plan. Second line may you can give 2 NRTI plus you give a boosted PI. What is the booster? The booster is that drug which I just told you, that is CoB-C-Stat. Then what is the treatment plan in adolescents? In adolescents, again the treatment plan is same, 2 NRTI plus 1 NNRTI, or you and oblique में integrase inhibitors. Second line में it is 2 NRTI plus 1 boosted PI. Okay, and here you give tenofovir plus lamivudine plus efavirenz, or you can give tenofovir plus lamivudine or emtricitabine plus D से आता है अपना dolutegravir. Okay, then the next in children 3 to 10 years, we give 2 NRTI plus 1 NNRTI. So here we give abacavir plus lamivudine plus efavirenz. Okay, and in children less than 3 years, we give 2 NRTI plus 1 PI, or we can give integrase inhibitor. Here it is 2 NRTI plus raltegravir can be given, and in children I forgot 2 NRTI plus boosted PI. So here the drug is abacavir plus lamivudine plus lopinavir, okay, plus ritonavir. So this can be, these are the treatment prophylaxis. If it is an infant, infant में prophylaxis हम क्या देंगे? We give zidovudine plus nevirapine for 6 weeks. Okay. Then post exposure prophylaxis, what will we give? For 28 days, start in 72 hours. Okay. Now in adults we will give tenofovir plus lamivudine plus protease inhibitor. Alternative can be raltegravir or oblique it can be lopinavir, ritonavir, or it can be efavirenz also. Then in children less than 10 years, it is zidovudine plus lamivudine plus lopinavir, ritonavir. Okay, and here abacavir can be used for zidovudine. So this is the therapy which we give for the prophylactic and treatment therapy for the patients for HIV. So with this we complete the antibiotics, and in fact we complete the whole of rapid revision series. Okay.